A 37-year-old man with a 10-year history of HIV infection comes to the office because of fever and a painful mass in his right underarm area for 1 week. 5 months ago, he developed painless red tumor like lesions on his skin after being scratched by a kitten. Despite treatment with a 2 week course of oral cephalexin, he has had persistent skin lesions and fever and chills. He has been poorly adherent to his antiretroviral therapy regimen, and his CD4 T lymphocyte count 1 month ago was 30. Physical examination shows skin lesions and a 2 centimeter tender right axillary mass. A biopsy specimen of the mass shows multiple clumps of dark bacillary organisms on Warthin starry stain. What best explains the delayed resolution of the infection in this patient? Please put your answers into the chat now. Before I turn it over to Dr. Nori, I just want to hear from the students. Not seeing the option set and having this question posed to you in this way, how was that for you?
Whenever I see an HIV infection, I always look immediately for a CD4 count to see what levels it's at because a lot of different infections occur at different levels of a CD4 count. So in this case, it's really, really low at 30. So I feel like almost any immunocompromised disease is on the table. Another big thing was he got scratched by a kitten. So probably an infection that's related with animals. And they also gave a specific biopsy test with the Wari starry stain. And that kind of got me thinking perhaps Pasteurella.
For me, whenever I see an immunocompromised status, it basically just widens my field so much more. So I start thinking there might be more zebras in the field than I would originally even think about. So just that, even in the first line, really made me expand. And then we got quite a bit of information in the stem with the low CD4 and then the organisms that were cultured and the stain that they used. So that gave me a lot of different things to think about.
I feel like I would have benefited more so by reading the question part of the question stem, and then going back to the like the vignette, because as we started reading, I was like, oh, this should just be an easy question. Like, what does he have? Like, is it like bacillary angiomatosis or something else? And then as the question progressed, it shows that it's a higher level question. And so then if I was taking a test, I would have to go back and read the question all over again because my mind had to refocus and kind of pick out what I was looking for based on what the question was asking.
The actual answer, though, I was having a tough time because I was thinking the CD4 T cells, and I saw some of the answer choices before me had said cell mediated. And I'm actually still a little confused because I was thinking it would actually be humoral because it's bacteria, but I don't think it's an intracellular. But I'm curious to hear what other thoughts are.
If the time is short, I look at the question and immediately goes to the paragraph, highlight the area that is related to that question. So that's usually helped me to save some time on NBME question.
I think this question puts us in a doozy situation where we are kind of like in a different mindset initially, and the final question kind of makes us think about something completely different.
It's really interesting to see how you all attack this type of question, because this is exactly how we would go about figuring out what the patient has had this individual presented to the emergency department. Our process when we write these questions and then we come up with the potential options to answer that question is we start with a case that usually we've seen in some clinical context, and then we try to satisfy the actual assignment. So each item writer is given specific tasks. The committee wants us to both address a certain disease state, but also a certain mechanism. And so we try to tie it all together and really get at what is the most important thing to take away for each disease state in terms of the mechanism, of how that disease acts or the mechanism of, let's say, the drugs used to treat that particular disease state.
Since you mentioned the committees, Dr. Nori, can you talk about the makeup of your committee? What kind of people are on there? It's not all just infectious disease doctors, right?
It is a really wonderful balance of practicing infectious disease docs who either take care of adult patients or pediatric patients, and also scientists, immunologists, allergists. And so it's a really multidisciplinary committee of individuals. And the way that we craft these items is first we start by doing them ourselves and submitting a bunch of questions to the committee. And then we get together either in person or these days by Zoom, and we help each other refine the questions further. We help each other make sure that these are not intended to trick, but they're really intended to get at the important concepts. And they're really fine-tuned over a course of multiple months to make sure that when you get to see them, that they're in their best form, meaning that they are there to test the most important concepts and not to lead you down an unnecessary path.